A very good morning to you all. I warmly welcome all of you to another session of CPD webinar series conducted by Society for Health, Research and Innovation. Without further ado, let's move on to the session. Today's topic is rare renal disease. Let me introduce our distinguished speaker today, Dr. Nadisha Nishanti, consultant nephrologist, Teaching Hospital, Anuradhapura. She is a product of Faculty of Medicine, University of Shijawardhanapura, and she got her MD Medicine in 2015 and received board certification as a consultant nephrologist in Sri Lanka in 2019. And she obtained European Specialty Examination Nephrology Certificate in 2021. Dr. Nishanti is an associate member of Royal College of Physicians, Edinburgh, and Ceylon College of Physicians. And also she serves as a member in training of International Society of Nephrology. At the same time, she has made significant contribution to numerous articles and research publications both locally and internationally under her name. Dr. Nadisha Nishanti is currently working as a consultant nephrologist at Teaching Hospital, Anuradhapura. Dear Madam, we are extremely proud and privileged to have you here with us today. Let's extend a warm welcome to our respected speaker who will share her expertise on rare renal disease. Over to you, dear Madam.
Thank you, Nisansa, for that kind introduction. I will share my presentation. So my patient, 57 years old, previously healthy patient, presented with frothy urine and ankle edema, which was gradually worsened over a month period. His baseline serum creatinine was normal, 1.05, and it was gradually worsened to 2.32. With UACR of 1751 with UFR protein 3+. And her blood pressure was 120/80 with blood sugar was normal. Calcium was normal and scan showed normal kidneys. And ESR was slightly elevated. So what do you think? So young adult onset nephrotic range proteinuria with slightly elevated ESR, and he's non-diabetic, non-hypertensive. So we did the renal biopsy. So this is the findings of renal biopsy. So it showed this mesangial deposition of eosinophilic hyaline materials, and these are the arterioles which showed intimal thickenings, and there is interstitial fibrosis and tubular atrophy. So the renal biopsy showed mesangial deposition of eosinophilic hyaline materials, interstitial fibrosis with tubular atrophy with lymphocytic infiltration of and 30% IFTA. And you can see the intimal proliferation. These are the vessels showing intimal proliferation. And the immunofluorescence, that is significant, was negative, and congruent was positive for amyloidosis. So the conclusion appearance with the renal amyloidosis with background interstitial nephritis. And here immunofluorescence was not available for light chain assays. So these are the congruent staining, and this is the renal biopsy finding. So we did the serum protein electrophoresis. This showed diminished albumin band, hypogammaglobulinemia with compatible with light chain disease. And we did the immunofixation, which showed free lambda light chain. And the lambda light chain concentration was significantly high. So let's move. What is this? So this is not multiple myeloma, as you all know, because bone marrow biopsy was completely normal. So what is it? Patient is having nephrotic range proteinuria, acutely rising serum creatinine levels, and the bone marrow biopsy was normal, but renal biopsy showed amyloid deposition, renal amyloidosis, right? So let's move on to what is it, right? So these are the origin of this monoclonal gammopathy of renal significance, I mean like the amyloidosis. So plasma cells secrete immunoglobulins, right? So immunoglobulins contain light chain as well as heavy chain component. So these immunoglobulins had 5 components, right? IgG immunoglobulins are there, IgE, IgD, IgM, and IgA. So these components contain light chains as well as heavy chains. In these disease conditions, there is a proliferation of one plasma cell clone. It can be IgM, IgG, IgE, IgA, or IgD. So when the secretion is high, with the one monoclone, one plasma cell clone, either these components, right? It showed a monoclonal band in the serum protein electrophoresis. This is what we can see, right? So there is suppression of other immunoglobulins, and there's a one clone is increased in concentration. This showed monoclonal band, right? So this is how this diminished albumin band, and this is polyclonal. When all the immunoglobulins are increased in a chronic inflammation, all the immunoglobulins are increased. So it showed polyclonal gammopathy. But if in a specific disease condition like multiple myeloma, so you see one clone is detected, one clone is increased. This is called monoclonal band, increase in the gamma region. So gamma region is the immunoglobulin region. So when we detect like that, we do serum immunofixation, because from the serum immunofixation, we can see which monoclonal band is affected, which monoclonal band is elevated. That's why when I'm seeing my patients who present with serum protein electrophoresis monoclonal band, we want to do immunofixation. Even though there's no monoclonal band, we will proceed with immunofixation to identify whether there is any increase of a clone, like increase of any immunoglobulins, whether IgG, IgA, IgM, sorry, IgG, IgA, IgM, kappa, or lambda. So this is from this immunofixation, we can see which one is elevated. Whether there is a increase in clonality of the IgG immunoglobulin, IgA1 or IgM1, or the light chains like kappa or lambda. So one immunoglobulin contains light chains or heavy chains or total immunoglobulin. So that's how we differentiate which one is affected. So in our patient, when we do the kappa lambda light chain assay, once immunofixation was done, we know that the lambda light chain was increased. Or kappa. In here, it's kappa. So kappa light chain was increased in amount, concentration. When we do the serum-free light chain assay, you can see there is an increase in concentration of kappa light chain, significant increase, with the kappa lambda ratio was significantly elevated. It was 57. So how do you differentiate monoclonal gammopathy? So this is very important to diagnose whether it's a multiple myeloma or MGUS or MGRS. That is how we diagnose. Bone marrow showed anyway less than 10% of plasma cells. So if the bone marrow shows more than 10% of plasma cells, we know definitely it's myeloma. But in our patients, most of the time, their bone marrow was negative. So sometimes my colleagues or my staff can ask, Madam, bone marrow was negative, so we have to negotiate. This is not the diagnosis. We have to, this patient is end up in dialysis, we have to dialyze. No, that is not. So we have to see, even though the bone marrow is negative, the renal biopsy showed these light chain deposition or the immunofluorescence or significant amount of immunofluorescence positive, or serum-free light chain assay shows positivity, or the immunofixation is positive. That is called MGRS. So how do you diagnose? Here we see light chain MGUS. So MGUS is very innocent. MGUS means there is no end organ damage. There is no end organ damage. But what is MGRS? When the clone plasma cell bone marrow shows less than 10%, and the renal histology and immunofluorescence shows this presence of these monoclonal proteins like kappa, lambda, or other immunoglobulins, and USCR positive. So then we need to treat as myeloma treatment, depending on the clone. I will let you know. So MGUS, we don't need to treat, just monitor. So the MGUS patients, because they are very innocent, they are having absence of an organ damage, but there is, when we do the serum-free light chain assays, that showed increment in the serum-free light chains and urine monoclonal proteins can be increased. So there are different categories like MGUS IgM, IgG, MGUS light chain MGUS, MGUS IgA. So, how do you treat? So, this patient was treated with dexamethasone, bodzimab, thalidomide regime like myeloma, and he got recovered. So, when MGR is suspected, monoclonal gammopathy of renal significance, when do we suspect? When a patient present with nephrotic or USCR more than 30 milligrams of millimoles, right? Sometimes patients' EGFR can be reduced, sometimes not. And their urine showed hematuria. I will point with this point is not working. So, and elevated free light chains. So, I will let you know what are the free light chain ratios. And then, when we do the bone marrow blood, there is a detectable clone. Okay, so once MGR is suspected, we need to do the renal biopsy. We showed kappa or lambda light chain restriction. So this is what these light chain ratios. So serum free light, when we do the serum free light chains, hope you all can understand. If you can't understand, just raise your hand, right? So this is little actually complicated. These cases are complicating. So if you don't know, can't understand, just raise hand, right? So the EGFR less than 30, the ratio is 0.5 to 3.4. It's like more than 0.5, 0.6, more than 1 to 3 ratios, then it is significant. Sometimes you might think because in the normal patients ratios and the lower EGFR patients ratios are completely different. Normal patient is 0.2 to 1.65, but in renal failure patients, that ratio is gone up to 1 to 3, right? So that is the significance. Okay. So how this renal kidney is affected with this monoclonal immunoglobulin? Hope you all could understood that when the clone is affected, when the clone is increase. Like, as I mentioned, when the plasma cells producing more immunoglobulins or light chains, that is that disease condition. When the light chains increased in concentration, independent of the tumor mass, so they cause like hyperviscosity syndromes, features like headache, pain tissue episodes, like hyperviscosity syndrome features, as well as they activate autoantibodies causing complement activation. So that's why these patients can show low C3, C4 levels. And it affects the tubules, cause nephropathy can occur. So because light chains deposits in the tubules, causing cause nephropathy, tubular disorders. That's how these MGRS patients present. Sometimes they present with proximal tubular pathies like or distal renal tubule acidosis, proximal renal tubule acidosis, because they cause nephropathy. And these cause autoantibody and complement activation and cytokine production, which cause interstitial fibrosis, that cause renal impairment, renal failure. Right? That's how these mesangial proliferation, that's how these affected. So these tissue deposition cause complement activation, cytokine production, and renal toxicity. Hope others can see this, right? Can others hear me?
Yes, madam, we can hear
All
you.
right. Okay. Shall I continue? Right.
Yeah.
So this is how these B cells, when they produce more plasma cells, as I mentioned you all earlier, there are some conditions where whole complete immunoglobulin secretion is high. So when the complete immunoglobulin, it can be IgG, as I mentioned, IgA, IgM, IgG, IgA, IgM, like that. So those, when complete immunoglobulins is secreted, they cause these conditions like cryoglobulinemias, immunotactoid glomerulopathy, and pigeonamides. If the light chain only secretion was high, they cause AL amyloidosis. As I mentioned, AL amyloidosis, mainly lambda light chain was concentration was high and lambda chain secretion was there. Sometimes it can cause kappa or lambda. Lambda was mainly affected. And then Fanconi syndrome, that's also light chain clone, and that causes proximal tubulopathy. There are other conditions, light chain deposition nephropathy disease and Cars nephropathies. And then we see heavy chain. Once the heavy chain deposition, this is called heavy chain deposition disease. So if the complete immunoglobulin affected, we call it as pigeonamides. Some conditions called polyclonal gammopathy causing diseases. This is called pigeonamide. Cryoglobulinias. I think you all know about cryoglobulinias. These affected the complement. When the complete immunoglobulin secretion was high, there's causing complement activation. That causes reduced C3 like that. And this is called immunotactoid glomerulopathy. Cars nephropathy is mainly light chain. AL amyloidosis also, it's mainly light chain, mainly lambda light chain restriction. So what are the histological findings of MGRS? So this is very important. In amyloidosis, light microscopy shows Congo red positivity, as I mentioned earlier. And it goes mainly light chains, secretion is high, either kappa or lambda, mainly lambda prominent, lambda restriction is there. We do not have electron microscopy. If the electron microscopy showed, it shows randomly oriented fibrils. Other conditions, as I mentioned, light chain deposition diseases, they affect mainly the tubules, Cars nephropathies, right? When we see some patients come with renal tubular acidosis, like that, they cause mainly proximal tubules. They deposit in the proximal tubules, causing proximal tubular swelling, right? Proximal tubule, kappa light chain stains. Other patients, as I mentioned earlier, when there is like total immunoglobulin secretion was high. These cause C3 glomerulopathies, right? So in the light membrane, when we do the renal biopsies, they shows membrane proliferation or mesangial proliferation. And the immunofluorescence shows C3 deposition. So the IF, IF කරනවානේ. So when we do the IF, it shows C3 plus plus plus. When the light chains deposits, they cause shows kappa and lambda, kappa or lambda staining. As I mentioned earlier, pigeonamide condition, that's also shows light microscopy shows membrane proliferative or mesangial proliferative or endocapillary proliferative glomerulonephritis, and the immunofluorescence showed IgG kappa in mesangium. So that means because you know that heavy chain and light chain both deposits. So the immunoglobulin part is also there and the light chain part is also there. So now I think you all can understand what is it. So when the plasma cells producing, when the plasma cell clone is there, when they produce more immunoglobulins, it can be either light chain or heavy chain or both components. When the both components deposits like pigeonamide, cryoglobulinias, they cause both IgG in the immunofluorescence as well as kappa. Okay, kappa or lambda in pigeonamide is mainly kappa. In amyloidosis, only light chain deposits and it causes mainly lambda. And light chain deposition disease also only light chains deposits and mainly it can be kappa. It mainly kappa light chains affected. And then C3 glomerulopathy, mainly there C3 is deposits because of the complement activation. So this slide is very important when you go for the histological findings. So in cryoglobulinias, it's both immunoglobulin with light chains, right? So cryoglobulinemia patients, they both type 1 and type 2. In the histology, they showed membrane proliferation or endocapillary proliferative glomerulonephritis with pseudothrombi. Right? There is light chain restriction in glomeruli and vessels. In light chain deposition diseases are variable and the most common pattern, because sometimes it might mislead with nodular glomerulosclerosis and thickened tubular measurement like diabetic nephropathy. Then renal biopsy can come as diabetic nephropathy features like nodular glomerulosclerosis and thickened tubular basement membrane, but it's not diabetic nephropathy. When the immunofluorescence showed linear IgG plus C3 and light chains that showed in light chain deposition disease. In Wander's macroglobulinemias, right? I think these are coming mostly for the ND part 1 MCQs. So it's light microscopy showed intraluminal deposits and the immunofluorescence showed IgM immunoglobulin deposition. As I mentioned, it can be either immunoglobulin whole or the light chain or the heavy chain. So if the whole immunoglobulin deposits, there are other conditions like pigeonamide D, cryoglobulinias, and Wander's macroglobulinemia. In the Wander's macroglobulinemia, immunofluorescence mainly IgM. Remember, in the IgM, the treatment is different. Okay, so if the light chain deposits, the treatment is different. If the whole immunoglobulin deposits, the treatment is different. So that's why we need to differentiate which immunoglobulin with either light chain, heavy chain, or the total immunoglobulin is affected. So this is MGRS related renal disease. So in the AL amyloid, as I mentioned, it mainly lambda light chains, and this shows electron microscopy, this organized fibrillary pattern. And in microtubules, we can see in this is immunoglobulin depositions. As I mentioned, cryoglobulin mainly immunoglobulins increased in concentration. So immunoglobulin deposits cause, we can see microtubule. In foreign countries, it's very easy to differentiate which condition because they have electron microscopy. Unfortunately, we do not have. In the and light chains, it's mainly like Fanconi's light chain proximal tubulopathies. It's mainly proximal tubule is affected. So the crystalline podocytopathy is there. So podocytopathy causing nephrotic range, and when the proximal tubule is affected, then you see proximal tubular disorders. And then non-organized immunoglobulin deposition causing, when the pigeonamide, as I mentioned earlier, this polyclonal gammopathy of nephropathy, pigeonamide is both immunoglobulins as well as light chains. So that causes IgG and C3. Sorry, IgG and kappa. IgG and kappa positive in the immunofluorescence. Immunofluorescence, you see light chains as well as IgG positivity. It is called pigeonamide. In C3 glomerulopathies, there is no immunoglobulin. This causes thrombotic microangiopathy. So it's different, right? C3 glomerulopathy is different. So I think you all can see it. So this is actually not very important. In Fanconi's, it's mainly kappa predominance with the other restrictions. Light chain also is kappa, and renal amyloid is lambda predominant. So this is very important. How do you diagnose, right? So kidney biopsy is required, right? Amyloidosis, actually we can diagnose without the renal biopsy actually, but we usually do it. In pathology, light microscopy showed congruous staining, and immunofluorescence showed immunoglobulin deposition. Either it's light chain restriction, heavy chain restriction, or the immunoglobulin cards, whether IgG or IgG or IgM. So in the, we do paraffin box, right? When we do paraffin blocks for light chain assays, right? So there are conditions there where clinical suspicion of MGRS, they are causing without detectable monoclonals, monotypic immunoglobulin deposition. So then those conditions, we need high sensitive techniques. So this is the diagnostic value of immunofluorescence studies, right? Sorry. So you can see either if it's IgG prominent, IgG deposition, lambda deposition, or the kappa deposition. And these are the findings of these immunofluorescence studies. So MGRS workup, we have to do, because most patients, serum protein electrophoresis will not show any monoclonal bands, right? So we have to do both serum and urine electrophoresis with immunofixations. So it is very important when we do the serum electrophoresis. Sometimes we can't see the monoclonal band, but to do the immunofixation, as I mentioned to you earlier, I will show that slide. This is the immunofixation results we usually get. So if the patient is suspect, when we do the serum protein electrophoresis, can be no bands. But when we do the immunofixation, we can see whether this IgG, IgA, IgM, kappa or lambda concentration band is here. So here IgG and kappa. So what is the condition of, as I mentioned earlier, when IgG and kappa is positive? It's called, can someone answer later now? So it's called Pigeonamide D. So they are both IgG and kappa is positive. So this is how this immunofixation is very important, right? So when we do, when I meet a patient, I usually ask serum to do serum and urine electrophoresis and immunofixation. And if it's so or not so, even though we go ahead with serum-free light chain assays. So serum-free light chain assays, it is very important to do kappa lambda ratios. So if for the renal failure patients, this ratio is different. So it varies from 1 to 3. Right? Imagine that kappa lambda concentration was very high, like 100 and both very high, but ratio can be normal. Still, if the concentration is high, we consider it as significance, even though the ratio is in the normal range. So it's very important to see the concentration, kappa concentration as well as the lambda concentration, and check the ratios. I hope everyone can understand it. So some analysis we don't need to know actually. We have more sensitive analysis with mass spectrometry and as other analysis. So improving the diagnostic performance of kidney biopsy in MGRS, there are other conditions like for the renal amyloid, very high diagnosis with this tendon mass spectrometry method, which is, I think, available in Maharagama Cancer Institution. When we want to highly specifically diagnose MGRS, with the renal bioamyloidosis diagnosis is not confirmed, we can do this method. So the hematology workup, even though bone marrow didn't show the plasma cell clone, we have to do with the serum protein immunofixation and serum-free light chain assay shows this light chain MGRS. We need to do bone marrow cytology and flow cytometry immunofluorescence to identify the clone. That is very important to treat, whether it's a plasma cell clone or the lymphocytic clone, because the treatment differs with either plasma cell or lymphocytic clone. So that's why it's very important to check the bone marrow for cytology plus flow cytometry immunophenotyping to detect the clone. And we have to exclude overt malignancies. If the plasma cell clones are there with CRAP features, CRAP and slim cap criteria, right? What are the criteria? More than 60% plasma cell infiltration with a free light chain ratio of more than 100 and more than one focal lesions on the MRI. Okay, so this plasma cell clone is affected. That means it's myeloma, right? There are diagnostic criteria of myeloma with cramp and SIMCAP criteria. And if it's lymphocytic clone was detected, it's like CLL and lymphomas, no? So anemia, hyperviscosity, hepatosplenomegaly, significant lymphoadenopathy, it's mainly lymphocytic clone. But here we need to know whether my patient, so imagine our patient, so he had serum free light chain ratio high, renal biopsy, it showed light chain deposition. We need to do the bone marrow to check the clone. Bone marrow plasma cells less than 10% definitely, because there is no clone. But we need to identify, there is no clonal detection, but we need to identify which clone is affected through these advanced techniques called bone marrow studies to identify the clone. So cytology plus flow cytometry immunophenotyping. Differentiating whether it's a plasma cell clone or lymphocytic clone is very important. So as I mentioned, this is very interesting because if the complete immunoglobulin secretion is high, these are the conditions Pigeonamide. As I mentioned, that previous immunofixation patient showed IgG and kappa, and then cryoglobulinias. Those total immunoglobulin secretion is high. Immunotactoid glomerulopathies. When light chains only, mainly conditions like CAS nephropathies and Fanconi syndrome, light chain deposition disease, AL amyloidosis, and this heavy chain deposition disease, it's mainly heavy chain is concentration is high. So immunotactoid glomerulopathy and Pigeonamide both uh, light chain and heavy chain, both was there. So complete immunoglobulin is there. So in the immunofixation, we can see IgG and kappa. IgG and kappa in Pigeonamide and immunotactoid glomerulopathies. So what is the principles of management? We need to see when a patient presented with MGRS, not for everyone we do treat. The patients established end-stage renal disease, okay, we need to find out whether this patient is a kidney transplant candidate or not. If patient is a kidney transplant candidate, yes, you need to treat. If the patient is not a kidney transplant candidate, we need to observe until patient is affected with other organs. If the other organs affected, yes, of course, we need to treat. If the frail patients, elderly, immunosuppressed, then we usually do not treat, right? So there is no overt hematological disease and the bone marrow short plasma cell or lymphocytic clone secreting immunoglobulin and the kidney biopsy positive for those immunofluorescence and kidney biopsy confirmed either amyloidosis or light chain deposition disease, then not for everyone, but the patients who are eligible for treatment, we need to treat. Like if it's like AKI, acute renal involvement, definitely yes, we need to treat because they nicely respond to the treatments, right? So, as I mentioned, we need to identify the clone with the bone marrow studies because from the renal biopsy, we can't identify the clone. If it's plasma cell clone, you need to treat as multiple myeloma. Imagine that's why it is very important to differentiate whether it's a multiple myeloma or a MGRS. So myeloma, definitely there is plasma cell concentration is high more than 10%. But in MGRS, my plasma cell concentration is less than 10%, but renal involvement there, immunofixation positive, serum free light chains positive. So we have to treat as plasma cell, and then we need to check the bone marrow for the clone. And once the plasma cell clone detected, we need to treat as myeloma, like bortezomib plus or minus lenalidomide, dexamethasone, like myeloma treatment rate. Sometimes they treat with melphalan and bortezomib or anti-CD38 regime. Lymphoma clone is detected. That's very important. So what are the patients with lymphoma clone is detected? When the bone marrow biopsy showed lymphoma clone, you need to treat with rituximab. Rituximab is freely available. right? So sometimes when we see like not identified, like we did the bone marrow, we can't identify a clone, but still we have to treat now because patients having AKI, nephrotic syndrome, and renal impairment, we need to treat. So if you need to, I think, guess that whether IgG, the immunofluorescence, renal biopsy immunofluorescence, so IgG, IgO, light chain only, it's anti-myeloma agent. Myeloma-like treatment should be there. If the IgM positivity is there, like Waldron's macroglobulinemia, it's mainly rituximab-based treatment. If when we using this melphalan and lenalidomide, so it's a potential nephrotoxic, but it's not contraindicated. Usually we refer to hemato-oncologist, and I will ask our hemato-oncologist to join as well. She will also join for this meeting. She will explain how to treat advanced, right? Okay, so we have to adjust the treatment dose and treat. So if there is, how do we measure the response with these free light chain assays, concentrations, whether it's reducing or not, right? And for the renal wise, we treat patients because they are coming with the fluid overload, the nephrotic syndrome. So I used to treat with diuretics and SGLT2 inhibitors as symptomatic in addition to this chemotherapy. So that's why very important to diagnose these kinds of patients rather than label them as end-stage renal disease. Because recently also we diagnosed a patient with who came with diabetic for 3 years, high ESR, nephrotic range proteinuria, and this renal biopsy showed very lambda deposition with serum free light chain was very high lambda chain concentration, and we started treatment with borzimab, and his edema responded nicely to treatment. So if we label them as end stage, that is so pathetic. So if we can't detect a clone, there is a new technique called RNA-based immunoglobulin repertain sequencing, rep sequence. This is called as rep sequence. This will show full length sequence of monoclonal immunoglobulins and which one is dominant. So if we can't find a clone through the previous techniques, this is the new technique to detect the clone. Which monoclonal immunoglobulin is affected with this RNA-based technique. This is how they identify the rapid clone identification, and it's not only available in European countries. We call it as RNA-based immunoglobulin repertain sequencing. So management of MGRS, that is include very important. In difficult cases, sensitive techniques required like RNA sequencing. So clone target therapy is the cornerstone. As I mentioned earlier, which clone is affected is very, very important, whether we treat with like myeloma-based regime, like borzimab, dexamethasone, and CD38 antibodies, or the rituximab-based treatment. If it's IgM positive or the lymphocytic clone is detected, you treat it as rituximab. So further works need to evaluate additional treatments. If the patient didn't respond, you can try with lenalidomide or other treatments, second line drugs. So you can go ahead with the third line drugs. So what is multiple myeloma? Bone marrow is anyway positive. So remember, this is myeloma and MGRS, MGUS differentiation is very important for the patients. Bone marrow plasma is more than 10%, and myeloma defining end organ damage, CRAP, we call it as CRAP, and free light chains more than hundreds, concentration more than hundreds, and there's hypercalcemia, anemia, bone marrow, bone lesions in the skeletal survey more than one lytic lesion. We confirmed the diagnosis of myeloma. That is very easy to treat. which is diagnosed with, if it's transplant eligible, we induce, and first we have to do this stem cell bone marrow uh, transplant, right? If the transplant ineligible, continue primary therapy. We imagine that this patient needs kidney transplant. First, you have to do the bone marrow transplant, and then only we go ahead with the kidney transplant, right? And these are the myeloma chemotherapy protocols like cyclophosphamide CRD regime, cyclophosphamide thalidomide dexamethasone regime, dexamethasone thalidomide and Vincris. These are the different myeloma regimes. And then another condition called smoldering myelomas. Those are innocent, right? Bone marrow plasma cells concentration is high, but they are asymptomatic. There is no organ involvement, there's no renal involvement, there's no other organ involvement, but the bone marrow is positive. These conditions called smoldering myeloma. So I think you all now know what is MGUS, what is MGRS, what is myeloma, what is smoldering myeloma. And then management of the smoldering myeloma, it's always observation with regular monitoring. And if the patient is having very high concentration where there's involvement, then you have to consider treatment. Okay, I think I have finished. Now it's time for questions and answers session.
Thank you very much, dear madam, for that comprehensive lecture. We have received a considerable number of questions, but I'll be moving on to questions which were actually not discussed during the session. And madam, I hope that you are not very tired to answer those questions. Okay.
Yes, I will try.
First one, madam, how common are the rare renal diseases in the community?
I think it is common, but we are not diagnosing it. That's my main concern, because we are coming across nearly 2 to 3 patients per month, and it's very common in the community. But the problem with, we are not diagnosing it accurately, so we are missing it as chronic kidney disease, end stage diabetic nephropathy. So that missing the diagnosis. That's why we are not diagnosing it. That's why we feel it like not common, but it's a rare condition. But we have to diagnose it. Okay.
Okay, madam. Next one. They want to know the availability of investigations to diagnose rare renal disease like renal biopsy with that cytology and flow cytometry and immunofluorescence. The availability in Sri Lanka, that means in private or government sector.
Yes, renal biopsy with immunofluorescence, which is available, freely available in our country. So these days, actually, Candy, they are not doing the immunofluorescence, but we are sending to MRI to detect the immunofluorescence. And this bone marrow for flow cytometry is available in both Candy Hemato-Oncology Unit as well as in Maharagama. And immunofixation, it is freely available. Serum for immunofixation and serum protein electrophoresis is freely available. Serum free light chain assay is available in MRI and also in private sector. I think I can ask, can you join Dr. Nilupuli, the hemato-oncologist? She's waiting in the room to join. Can you ask her to join? So it's available. So we can diagnose it because we do diagnose with serum free light chain assays and immunofixations. Okay. And clone detection is also there. That's why most patients we send for clone detection with the bone marrow, and they detect it, whether it's a plasma cell or a lymphocytic clone, and we target that clone.
How to minimize progression of rare renal disease before they are identified, and who are the people who are at risk of developing these diseases?
So that is very important question, right? So when we detect patients, right, so we can treat with diuretics and SGLT2 inhibitors and diagnose them early, and treat them early is very important. That's why I told there's one patient whose creatinine was earlier 1.1. and it has rapidly gone up to 400s. Like we did the renal biopsy, and its light chains was positive for lambda, and we did the bone marrow, which was negative. And with as the lambda light chain was ratio was high, and the renal biopsy showed immunofluorescence source lambda chain deposition, we referred for the bortezomib and dexamethasone treatment, and he nicely responded to that. So like that, there are patients. There's a one patient with renal amyloidosis, and actually that patient I had referred to Nilupali, and she had nicely treated with the chemotherapy regime, and his renal functions nicely respond. So the early detection and early diagnosis and early treatment is very, very important. We should not be very scared to give those immunosuppressants. I mean, not the frail patients, but these patients who are eligible for these treatments, we need to treat them earliest as possible before these patients get into end-stage renal failure. In the meanwhile, if the eGFR is more than 20, we can try with SGLT2 inhibitors, diuretics, and if the diabetic, we treat them with proper glycemic control and fluid management if the patient is dehydrated. And then supportive therapy is very important. With the supportive therapy, in addition chemotherapy treatment, that is very important.
Okay, madam. There's another question. What is the role in ultrasound in early detection of rare renal disease?
Ultrasound, the role is whether this kidney is biopsiable or not. That's it. If the biopsiable, definitely, I usually proceed with the renal biopsy. So ultrasound role is one thing to detect whether it's biopsiable or not. Other thing, whether there is any other causes of AKI which is need to be intervened earliest, like whether it's at hydronephrosis, whether superadded pyelonephritis, like that. Biopsy mainly I do to treat whether patient is biopsiable kidney. Usually, if the kidney size is more than 8.5 centimeters, I usually do the renal biopsy. And if the cortical thickness is good and the corticomedullary demarcation is okay, proceed with the renal biopsy. Do not scare do the renal biopsy. Proceed with and diagnose it and treat them.
All right. Then, when it comes to MGRS-related renal disease, what are the indications for renal transplant? Is it indicated? If so, what are the indications?
The indication for renal transplant, as I mentioned, is if the patient had established end-stage renal failure, and if the patient is fit for transplant, you have to do the transplant, and following the transplant, we need to treat the condition. Post-transplant also, we need to continue this treatment regime, chemotherapy regime. That's why I told if the patient is eligible for the kidney transplant, only anyway, if the patient is established end-stage renal failure, and if the patient is fit for transplant, you have to treat first. That's why even though established end-stage renal failure, if the patient is a kidney transplant candidate, you need to treat first. And then following the transplant also monitor the patient for that disease relapse and treat for the disease. So that is why it's most important, very important, if the patient is eligible for kidney transplant, treat the disease. Imagine if the patient is not eligible for the kidney transplant, then and patient had established end-stage renal failure and only kidney is involved and there's no other organ involvement, then there's no point treating with just these immunosuppressive drugs. Okay. So because just treating immunosuppressive drugs for established end-stage renal failure patient, there's no point. Right? So if the patient is eligible for kidney transplant, treat the disease and do the kidney transplantation. Okay?
All right, madam. They want to know whether there's a place for genetic screening in rare renal disease.
Rare renal disease genetic screening, actually, I think Nilupuli can answer for that question. Because I do not know about genetic screening diagnosis from genetics. It's mainly with this renal biopsy and bone marrow for the clone detection and immunofixation.
All right. And there's one question, madam. What are the organs mainly affected by renal amyloidosis?
Yes, renal amyloidosis is mainly kidney. Amyloidosis, there are the organs like bone marrow and GI. So, and soft tissues like tongue. So, amyloid, it's a whole entity. There are entities, only renal amyloidosis, only kidney is affected. So that is why it is very important to diagnose this renal amyloidosis, because these conditions only kidney is affected most of the time. But in the amyloidosis, most of the other organs also involved, right? Bone, soft tissues like and GI. Right, so almost many other organs involved in renal amyloidosis, but renal amyloidosis sometimes only kidney is only affected, and we need to treat the renal amyloidosis with these treatment regimes.
Last question, madam. Does bortezomib cause renal failure?
No, no. It never causes renal failure. You can treat with bortezomib for renal failure patients. Only we need to be cautious with melphalan, lenalidomide, thalidomide, those. Rituximab, bortezomib never cause renal failure. So that's why it's very important to identify the clone and treat them. Yeah, this lecture I mainly targeted about this differentiating. I don't know, no one had asked any questions about pigeonamide, immunotactoid, and light chain deposition diseases. I don't know whether they understood those conditions. So cryoglobulinemia is very important, where there is total immunoglobulin deposits causing complement activation and mesangial in the renal biopsy tissues, causing nephrotic syndrome, which is treatable, right? And pyramide is very important, where there's complement affected and both have heavy and light chain deposits. Okay.
I think they might need some time to go through the lecture,
Yeah, I
madam.
think
So
it's
they will come
very
up with
complicating.
yeah.
That's why I think.
So madam, are we having Dr. Lidupuli Gururatna with us?
Yes,
Yes, sir?
I will contact her by the phone. Then let's join her through the phone.
Hello.
Nilupuli, can you join through? It's okay. Can you? Yeah, that's okay. Can you join with me, us with the phone? Now everyone is listening. They are asking in the country, in our country where this bone marrow clone detection is available. Bone marrow clone detection with cytology and flow cytometry. I think it's available, right? To detect plasma cell and lymphocytic clone.
Yeah, it's
Yes.
available.
It's where?
available.
Where? Because they want to know where.
It's available in Maharagama.
Okay. So it's available in Maharagama. Okay.
Available in Canada.
Handy. So both centers it's available. So other, sorry?
It's available in
Jaffna.
Yeah.
Oh, that's good. Great. So it's available in Jaffna as well. Other question they asked about, I mainly highlight about the renal amyloid. So they're asking about AL amyloidosis treatments and the organ involvement. Can you just summarize about that? Yeah.
So, like to share experience.
Experience. So she says sharing her experience. Yeah.
Amyloidosis. That's amyloidosis for us. However, there are considerable number of patients coming with the cardiac as well as, in contrast to the presentation, cardiac as well as the skin amyloid. And I have the vocal cord and only the vocal cord.
Only the vocal cords. Okay, that's great. Only they usually, I forgot to mention about cardiac amyloid. It's mainly restrictive cardiomyopathy they present most of the time. So, and as she mentioned, there's a patient who presented with only vocal cord affected. So you all did the vocal cord biopsy, right? Okay.
Vocal cord biopsy, that's treated with radiation only, not the chemotherapy.
Okay, radiotherapy only for the vocal cords. Okay. So if it's skin infiltration, what is the treatment? Skin.
Skin.
Yeah. Cutaneous.
Yeah, cutaneous ones. Try to give localized.
Localized. Okay, localized treatment. So for these other, it says cardiac amyloidosis, how do you treat? So the renal, as you mentioned, we treat as myeloma, right? Renal amyloidosis. Yeah.
What we have to treat like myeloma, and the prognosis is worse than the, I mean, in contrast to the myeloma, the poor prognosis, myeloma, cardiac amyloidosis, also we treated myeloma.
Okay. As my cardiac amyloid also, it's myeloma treatment regime, right? Okay. And skin mainly local treatment. Okay. So Nilupuli, there's one more question, which they asked about the genetic predisposition for this MGRS, because I don't know about that.
So most of the time acquired. It's acquired genetically. Familial.
Okay, so it's acquired, right? Okay, thanks. So we do not have that advanced technique of RNA-based sequencing technique to detect the clone in MGRS, right? We don't have that, right? Sorry.
Radiologically, the ideal scan is the serum amyloid protein scan. That is only available in developed, even England, London. Only available center was in London. So it's very rare to detect the radiologically amyloidosis.
Radiological, right. So usually PET scan, can we detect from the PET scan? No.
No.
Okay. Sure. If it's myeloma, you can detect, but not the amyloid, right? So we can do bone marrow cytology and flow cytometry to detect the clone in MGRS. And tendon mass spectrometry, do we have it?
Which one?
Tendon mass spectrometry, spectrometry.
No,
we don't have. So that we can detect the renal amyloid, right? From the amyloid lesions if we do that technique. Okay, so any other questions we have? Any important ones? So here Nilpili, they asked about the kidney transplant. As I mentioned, who are fit for the kidney transplant, first we need to treat with this myeloma treatment regime. Once they achieve the remission, then go ahead with the kidney transplant. And following the kidney transplant, monitor for the disease, right? If the patient had the disease, we again treat with them, right? And monitor, right?
Yeah, and actually bone marrow transplantation also indicated, and then kidney transplantation also indicated, depends on the recovery, and then the maintenance.
Yeah, imagine if the patient fully recovered with the chemotherapy, still do we go ahead with the stem cell bone marrow transplant prior to kidney transplant?
That's the consolidation therapy. Considering the prognosis of amyloidosis, that is recommended. And we have recently also we did skin amyloidosis and renal amyloidosis patient transplanted in Jaffna.
Right.
So just start. It's the treatment despite the remission, because it's the consolidative treatment in terms of having durable remission.
Sure. So you go ahead with both first bone marrow and then the kidney transplantation. Any other questions?
No, madam, that's all we have got.
So as I mentioned earlier, I think Nilupuri agreed. So we need to detect the clone, and if it's plasma cell clone, we go ahead with botsumab. and no anti-CD38. If it's a lymphocytic clone, that is very important. That's why it's rituximab-based treatment. Sometimes we can't see the clone, but the renal biopsy shows immunofluorescence showed whether which one is predominant. We see whether it's IgM-based or IgG, IgA, or light chain. So if it's IgM predominant, we treat with rituximab like Walden's. And if it's IgG, IgA, or light chain, it's mainly like myeloma treatment. So you used to treat with as myeloma, and as Nilupil, I think you agree, we should not wait until the patient develop end-stage renal failure, right? So we need to treat with chemotherapy first, earliest as possible, right?
Yeah, because
Sorry?
but yeah.
Sorry?
Hello? Hello?
Yeah.
Yeah. So I got the patient, patient came with cardiac failure. There wasn't any identified cause. He did the cardiac biopsy also. In the cardiac. Only he improved with chemotherapy. I mean, we gave a kind of chemotherapy.
Right.
Because likewise, renal recovery also not realistic without chemotherapy.
Yes.
And the other thing is, we don't have all the sophisticated investigations, sometimes not even paraprotein light chains not readily available.
Yes.
So that clinical concerns, if there is a clinical concern and if MDT agree, I think rather than going ahead with the renal replacement therapy alone, better to consider systemic therapy.
Yes. So yes, sometimes if it's indicated only, we will go ahead with temporary renal replacement therapy, but with the same time, we are continuous with the chemotherapy. So other thing about, I mainly focused on this renal toxicity, MGRS actually. So as amyloid also, its treatment regime is similar to, as Nirupali mentioned, myeloma treatment, if I'm correct, right? So, and then if the planning for kidney transplant, we can proceed with the bone marrow transplant prior to the kidney transplant. There's no contraindication, right, of botulism in renal impairment, and it's very treatable. And identifying the clone detection is, I think I'm correct. If it's clone detection is very important, and we need to identify and diagnose it early to treat them early. So we don't have these newer techniques for identifying clone detection with these RNA-based treatments. So MGRS management, it's rapid, and we are not target treatment for patients who had established end-stage renal disease. Only kidney is involved without any other organ involvement. And if they are not fit for the kidney transplants, we are not target the treatments. Yeah, right. So I think it's finished. We can finish now. I think, Nilupali, you can share about the recent patient. We have referred to Candy, the patient who was renal amyloidosis, who came from Polonnaru to Anuradhapura and then to Candy. Initially you treated with botulism, right? If I'm correct, who was diagnosed with amyloidosis.
Yeah, he got sepsis and autonomic neuropathy. That's a non-complication of and then severe hypertension as well. So that's why, because of the adverse effect, we have to change the second line. We have to change to a second line treatment. Now he's on second line therapy with oral nimelenimide and prednisolone monthly followed up in our clinic. And actually we got we received many patients adult onset nephrotic syndrome with high ESR, some changes, raccoon eyes. I mean, it's not really raccoons, but it's sometimes I know the vigilance is very important, I'm telling. Because we received many adult onset nephrotic young patients, 30s and 40s.
Sure. So this patient, she treated with botulism, and when there's no response, they changed to lenalidomide with adjusting the dose according to the EGFR, as I mentioned earlier, and now he's responding. So that's why it's we should not misdiagnose or miss the diagnosis of this MGRS, right? Always diagnose and refer to treatment. I think now it's, thank you so much for joining with us, Nilupali. Right? Okay, right. I think we can end up our discussion, right?
Yes, madam. With that, we have come to the end of the session today. I would like to thank Dr. Nadisha Nishanti, consultant nephrologist, teaching hospital Anuradhapura, and Dr. Nilupuli Gunaratna, consultant hemato-oncologist, National Hospital Kandy. Dear madam, thank you very much for the thought-provoking lecture on rare renal disease. We had very clear explanations and practical insights from you. I'm sure most of the participants got benefited from the session. I sincerely like to appreciate your time, expertise, and your contribution on behalf of Shri for the enhancement of knowledge of the participants. Thank you very much again, dear madam. With that, I would be moving on to the end of the session. So please find the link in the chat box and kindly give your feedback. And at the same time, answer the post-assessment questions so that you will receive your e-certificate for participation. You'll have access to the recording of the session in our official YouTube channel. I invite all of you for another interesting session on next Sunday as well. So have a good day. Thank you very much.